Welcome to the Healthy Living Series, a series of talks brought to you by the University of Alaska's Summer Sessions and Lifelong Learning in partnership with Foundation Health Partners. My name is Joan Braddock, and I will be your host for this summer series. I am delighted tonight to introduce our speakers for this evening, Dr. Mishelle Nace and Dr. David Bridgman-Packer, who will be speaking on COVID-19 in children. Due to the timeliness and importance of this topic, the talk will be presented in two parts, with the second part aired next Tuesday night. If you miss one part of the talk, remember that you can also view the talks online from the Summer Sessions' website. Dr. Nace, a pediatrician at the Tanana Valley Clinic, received her medical degree from the University of Washington, Seattle, and completed her residency at the University of Washington's Children's Hospital Medical Center. She is a board-certified pediatrician and the current medical director of the Tanana Valley Clinic Pediatric Department. She has been with TVC since 1996 and is the mother of 3 children. In her pre-COVID free time, Dr. Nace enjoyed spending time with family, running, and traveling. Now she is focusing more on family and running. Dr. Bridgman-Packer is a resident physician in pediatrics at the Tanana Valley Clinic, as well as the University of Washington Seattle Children's Hospital. He completed medical and public health school at Columbia University in New York with a focus on health law and public health policy. In what free time he can scrape together, he enjoys biking, hiking, and figuring out how to have fun in our new world of physical distancing. Tonight, Dr. Nace and Dr. Bridgman-Packer will be presenting the first part of their talk on the very timely topic of COVID-19 in children.
I want to thank you for inviting us to talk here tonight. You notice that I'm wearing a mask. I'm going to take it because I am socially distanced. I'm greater than 6 feet from others, so it will be better able for people to be able to understand me. Tonight we're going to talk about a couple things regarding COVID. First, we're going to go over with my colleague, Dr. Bridgman-Packer, the basics of COVID to understand it again at the level, as well as to understand what it does, symptoms, and to understand COVID as an entity. We're also going to go over how it impacts school and starting schools, as well as dive into a little of the resiliency and what the COVID experience and the difficulties of it, what opportunities and what chances it does have to offer us in its experience. We also have a couple demonstrations we want to show to see firsthand when we talk about some of those words like PPE or masks or different kind of masks or N95 to show you what those are to help understand those better. And then we're going to go over some questions and answers that we had collected prior to this lecture to be able to address some specific questions. The one thing that COVID has taught all of us is that it's redefined planning. Trying to plan what you do this week and next week and the following week is constantly changing. COVID has taught us that midstream you can have this plan and suddenly you're going this way because COVID has changed what we knew. We've learned we need to be flexible, we need to be nimble, and we need to be able to adapt. We've also learned that we need to be able to lean on each other to get through this, and we can get through this, but we do need each other to do it. So at this point, I'm going to turn it over to Dr. Bridgman-Packer to talk a little bit about COVID.
All right, thank you so much, Dr. Nace. Now that everyone is 6 feet away, I'm going to take off my mask. So my name is David Bridgman-Packer. I'm a resident physician here in town in Fairbanks, and I also work at Seattle Children's Hospital. I'm going to be talking first a little bit today about the science of the disease, the novel coronavirus and COVID, what we know so far about the symptoms that the disease causes, how it moves through our communities, and then to look a little bit about what we've seen in Fairbanks so far. So in terms of the science of the virus, we know that there are 7 known coronaviruses that infect humans. Of these 7, there are 4 coronaviruses that we've actually been used to seeing quite often. These are viruses that cause the common cold, runny nose, fever, sniffles. We're very used to seeing these viruses in the hospital and in clinic. And these viruses generally cause fairly mild disease. However, we also know from prior experience that there are coronaviruses that we've seen before that can cause severe disease. The first one that emerged was in 2003, and that was SARS, also known as SARS-CoV or SARS coronavirus. And this virus showed us that there are coronaviruses that can cause more severe forms of disease and also can often cause death as well. The second more severe coronavirus that we saw was MERS, or Middle East Respiratory Syndrome, and that emerged in 2012. In both of these cases, the viruses were more severe, but the public health systems around the world were able to contain the viruses and were able to prevent the type of pandemic that we're seeing today. This brings us to 2019, where a new coronavirus came that was SARS-CoV-2, or the novel coronavirus. And as we'll talk a little bit later, this virus has a few features that have allowed it to become widespread throughout the world, as well as cause severe disease and in many cases death as well. And this is the source of the pandemic that we're dealing with right now. I want to step back a little bit and talk a little bit about how we become infected by viruses. So what is a virus? A virus is essentially a capsule, a bag, that contains genetic material. And for us, we have DNA in our cells. Viruses often have RNA in there that they carry. And so a virus is essentially just a little bag, a little package of genetic material. It's wrapped in a capsule of proteins, and then it often has additional proteins on its surface. And in the case of SARS-CoV-2, one of these proteins is known as the spike protein. And that protein, in combination with several others, allows it to attach itself to the cells in our body, most prominently the cells in our respiratory tract and in our lungs. And it causes the virus to then pass through that barrier and invade our cells. Once in there, the genetic material, the RNA in the virus, gets replicated. The proteins of the virus also become replicated. They become repackaged in new forms of the virus, and the virus multiplies over many-fold. And then the virus then escapes back out into the environment. And as we'll talk about, it escapes back out through breathing, talking, sneezing, coughing. And this is how viruses can infect us and also how they can replicate and spread. Next, I want to move on a little bit to the symptoms of the virus. Now, this is a novel virus. As a medical community, we've only had less than a year to understand this virus, and our knowledge of the virus constantly is updated and constantly changes as new research is done. So initially, we were seeing this new virus, and we knew that it caused fever, we knew that it caused cough. But as we've gained more information, we've seen other symptoms start to develop. And we've seen some unusual symptoms, things like loss of smell, loss of taste. And these are symptoms that are more unique to this virus and that we see actually quite frequently in people who have become infected. We can also see other cold symptoms, things like sore throat, headache, and then we can see gastrointestinal symptoms emerge, things like vomiting and diarrhea. For more severe cases of COVID-19 being the disease caused by the novel coronavirus, we can see many different complications in adults, ranging from kidney disease to strokes, and a whole host of other complications. From the pediatric world, I want to mention a little bit about what we know in terms of what symptoms we see in children who have COVID-19. And what we know is that overall, children appear to represent with somewhat less severe forms of the illness. We know that about 50% of children have fever. We know that about 50% of children have a cough. And that means that many children who are carrying the virus present without those symptoms. We know that up to about 20% of children are asymptomatic, meaning that they are carrying the virus, but they are not presenting with any symptoms at that time. And so overall, we see lower severity of illness in children than we've been seeing in adults. However, at the same time, we have seen many cases of children, especially children with other medical conditions, become severely ill and rarely, but at times, die from this disease as well. I want to touch on one other complication that we've seen from this disease in children, and that is something that has been labeled MIS-C, or multisystem inflammatory syndrome in children. And this is a very rare complication that we've been seeing as a medical community, where several weeks after becoming infected with the virus, children will develop several days of elevated fevers as well as a host of other inflammatory symptoms. And when we look at the laboratory tests for these kids, what we're seeing is that they have antibodies to the virus, which means that they previously have had the viral infection, but we're not finding evidence of active viral infection for these children. And that makes us think that when we see kids with this multisystem inflammatory syndrome, their bodies have actually fully cleared the virus. They're no longer infected, but their body continues to act as if it's infected, revving up its inflammatory engine. And that over-response of their body is causing harm. And so again, this is something that we see very rarely in the pediatric community, but something that we need to be aware of. Third, I want to talk a little bit about the different ways that we know that this virus can spread. The first route of transmission that I want to talk about is through droplets. Now, what are droplets? Droplets are small drops of water or that then have the virus in them or are coated with the virus. And these droplets can emerge when I am breathing, when I'm talking, when I'm coughing, when I'm sneezing, and they're projected out in front of me. You can think about in the cold weather when you're breathing, you see that plume of air become visible in front of you. Well, a similar thing happens every time we breathe, every time we talk, every time we cough, every time we sneeze. And we think that these droplets are emitted into the air, and then after a short distance, they fall to whatever surface is beneath them. And we think that about on average, these droplets go about 6 feet before falling. Some fall sooner, some can fall farther. But on average, we think that they go about 6 feet. And that's where the guidelines around physical distancing and keeping that distance of 6 feet come from. Again, that's an estimate, and our understanding of that distance and the dynamics of these droplets is still evolving. The second route of transmission is surfaces. So after these droplets emerge, they land on surfaces, and then if another individual touches that surface and then touches their mouth, their nose, their eyes, they can then become infected with the virus. There is a lot of research going into determining how long the virus can survive on a surface. It seems like a lot of it depends on what type of surface it is, what kind of environment it is, how humid it is, what the temperature is. But we're usually talking about something on the order of hours to days that the virus can survive on surfaces. And this is where a lot of our recommendations around hand hygiene and cleaning come in to try to prevent the viral spread from surfaces and also from one person's skin onto another. The third topic that I want to talk about in terms of viral spread is spread through aerosols. So what is an aerosol? Well, first I talked about droplets, and droplets come in many different sizes. On the smallest end of that spectrum are aerosols, and these are tiny little droplets that instead of falling to a surface after they're emitted, they can remain elevated in the air. And these aerosols are particularly dangerous because an individual could project these aerosols into the air, leave a room, another individual could come into the room, breathe in that air, and become infected without ever making direct contact with the first individual. Now, there's a lot of research in the scientific community and a lot of controversy right now about how significant aerosolized spread of this virus is. But we are starting to understand that the places where aerosolized spread occurs generally tend to be indoor spaces that are crowded and that have poor ventilation, where the air is remaining stagnant in that space and isn't being moved in and out, providing fresh air to the people in the room. And so this is where a lot of our thinking around the importance of ventilation comes in, when we want to make sure that the air in rooms is being cleared of any potential aerosolized droplets that are containing the virus. In terms of spread, I again want to make a little bit of a distinction between young children and then adolescents and adults. A lot of research is being done right now to try to determine precisely how likely one child is to transmit the virus to other children and other adults. At this time, we don't have an exact answer. A lot of it depends on the environment where children are, and a lot of it depends on the overall prevalence of the virus in the community. But what a few of the studies we do have are saying is that it does seem that younger children, especially children in kindergarten and elementary school, seem to be slightly less likely to transmit the disease to other children and other adults. However, that question is still very far from being answered definitively, and a lot of research is going into answering that question. On the topic of the severity of illness that we see with COVID-19, as well as the ability of the virus to spread, I'd like to next talk a little bit about how we think about these two concepts in the setting of a new virus. So what we see is that viruses that tend to cause very severe illness tend not to spread very widely in our community. And the reason for that is that if I become exposed to a virus that causes severe illness, and if I become infected, I am likely to become quite sick rather quickly, and that's going to lead me to present to a hospital quite quickly. I'm not going to have time to go to the grocery store, to go to friends' houses, to be in public, and I'm not going to have those opportunities to spread the virus to others. And so that's why with more severe viruses that cause more severe disease, we tend to see that they spread less quickly throughout our community. And that's, to some degree, what we saw with the first SARS coronavirus, as well as with MERS, that these were viruses that caused severe disease, but they were able to be contained through a lot of public health efforts. On the other side, we see that viruses that cause more mild forms of disease do tend to spread widely throughout our community. And these are viruses like the common coronaviruses that we see regularly in the hospital and in the clinic. And these just cause some cold symptoms, but because individuals who have them often don't think to get checked out or don't even know that they are carrying the virus, will spend more time in public spaces and therefore give the virus more opportunities to spread. When we look at the dynamics of the novel coronavirus, we see that it is breaking these rules that we previously used to think about viruses, because in most individuals, COVID-19, the disease caused by SARS-CoV-2, is actually a mild disease. Most individuals only have mild cold symptoms, or the other symptoms that I listed earlier. And because of that, if I am infected with SARS-CoV-2, and if I have mild symptoms, I may be asymptomatic, I may not know I'm carrying the disease, or I may not think to get tested. And that gives the virus the opportunity to spread when I go to the grocery store, when I go to school, when I go to other public places. And that has allowed the virus to spread very widely in our community. However, for some of us, especially those of us who have pre-existing conditions, who have advanced age, or who otherwise are more susceptible to the virus, COVID-19, as we've seen throughout the world in Fairbanks and throughout the United States, can have very severe disease and can lead to death. And in that sense, COVID-19 falls into this earlier category with SARS and MERS, where we see these severe forms of the disease. But it also falls into the category of the common coronaviruses, where its ability to spread throughout our community puts us all at risk of contracting the virus. The next thing I want to talk about briefly is epidemiology, which is the study of the transmission of diseases and how viruses and other infectious diseases spread through our community. I have a couple scenarios here. And let's say that these pyramids of little stick figures, you're going to have to forgive my drawing because I went to medical school instead of art school. The pyramids of stick figures represent our community in Fairbanks. So let's say that one individual becomes infected, and that individual passes the disease along to another 2 individuals. And the disease continues to spread through the community, with each individual infecting at least 2 others. What we then see in that scenario is an exponential increase in the number of cases as time goes on. And this is the curve that we've seen in many communities throughout the United States as well as worldwide. And this is the curve that happens when the virus is not controlled. So let's take another scenario where the virus is introduced to a community like Fairbanks, where one individual becomes infected, and that individual starts to transmit the virus to others. But let's say that several members of the community take steps to prevent the virus, through physical distancing, through masking, etc. The virus can try to spread, but it's not able to spread as quickly. It runs into these barriers where appropriate measures are being taken to prevent its spread. And here you can see that these individuals who took these steps to prevent transmission of the virus not only protected themselves, but they protected everyone behind them. They protected their friends, their family, and overall they've reduced, and in this case, stopped the spread of the virus in their community. And so when we look at that on the graph, what we see is that initially viral transmission increases, but then it starts to plateau. And as long as these measures continue to be taken, we see that the rates of virus actually drop off. Now here comes the rub, because the virus has only dropped off because members of the community took steps to prevent transmission. And if those members of the community or the community at large stops taking those steps to prevent transmission, the virus can resurge or it can be reintroduced to that community. And that too is what we've seen in Fairbanks, in many parts of the United States and across the world. That initially there was a peak in viral cases, it was well controlled, but now we're seeing that second surge. We see that the rates of virus start to increase. So today I went to the Alaska Coronavirus Hub that's on the Department of Health and Department of Health and Social Services website. This is accessible for everyone and you can check it out. And what we see here is exactly what I drew before. We see in March of this year that initial spike in cases, but that spike was quickly controlled when our state took a number of steps to mitigate the spread of the virus. We went through late April and much of May with very low levels of cases, but then into June and now in July, what we're seeing is this second surge, this exponential increase in cases. And this is the story of what happens when steps are initially taken to mitigate the virus and the rates come down, but when that virus is persistent and when we need to continue to take the additional steps. In terms of flattening the curve, I want to talk a little bit about how the rate of transmission in our community can impact the resources that we have in our hospitals and in our clinics to assist those who have COVID-19, have the illness. So let's take a scenario where the virus is initially uncontrolled. We see a significantly elevated peak, and then the virus becomes controlled again. Now let's say that this curve represents all of the individuals in our communities that require hospitalization, that require hospital level care to support them through the infection and through COVID-19. What we've seen in many communities across the United States is that that peak actually goes above the number of beds, hospital beds, that are available in that community. So let's say that this dotted line represents the number of beds that are available. Here we have this group of people who became ill and needed hospitalization during the pandemic, who did not have a hospital bed that was available for them. And it's in this group of people that we see increased rates of complications, more severe forms of the disease, and unfortunately in many communities across the United States, increased mortality rates because the resources in the community are not available to provide them with the best possible services that they need. Let's take another scenario where initially the virus starts to increase, but the community takes actions to mitigate the transmission of the virus. And in this community, the peak is lower and the virus tails off. In this community, at its peak, the number of individuals who required hospital-level services was below the total number of beds. And so the medical resources in the community were able to meet the needs of that community and were able to provide the best possible quality of care for individuals who needed it. Thankfully, in Fairbanks, we have not seen the first case yet, but this is the concern of healthcare professionals, that at some point, this community, as other communities in the United States that we've seen, could get to the point where our medical resources are stretched. So let's take this information and bring it down to earth a little bit and look at the numbers that we're seeing in Fairbanks. So this is from the DHSS website taken today. In Fairbanks, we've seen 378 total cases across the course of this pandemic. These are individuals that have tested positive for the virus. We currently have 266 active cases, meaning individuals that are still either having symptoms or in that window when they could potentially transmit the virus to others. And we have seen a total of 5 deaths now in our community. I want to talk a little bit about how we think about these numbers, because these numbers, in terms of total cases and active cases, only represent individuals that have actually tested positive for COVID-19 and for SARS-CoV-2. And what we know from studies in other communities across the United States and across the world is that no matter how perfect our testing is, we're not going to catch everyone. We're not going to be able to test everyone who potentially has the virus. And so that number is not going to represent the total number of people in our city or in our community that have SARS-CoV-2. In fact, we know that testing, even in the best of cases, actually only finds a minority of individuals who have the virus. And so a rough estimate, a rough rule of thumb that we use is to take those total number of cases and multiply it by 10 to account for all of the cases that are potentially out there where individuals were asymptomatic or maybe had mild symptoms and didn't think to be tested. And so when you see the numbers in the paper each morning, that's a rough rule that you can use to estimate how prevalent actually is this virus in our community. Again, that's based on studies in other communities, and that's a rough estimate, but that's one tool that we can use. And then I want to talk a little bit about how we think about the different levels of risk in terms of viral transmission in our communities. One number that is very helpful for us to look at is the number of cases per 100,000 individuals per day. And in Fairbanks, North Starborough, it's actually quite easy to calculate because we have a population of about 100,000 individuals. And so on the website, you can look at this number. This is the average case rate. And what we do is we look at the number of cases per 100,000 individuals per day. And then we average that out over a 14-day span to account for any noise that might be in the data. What we see right now is that we're seeing about an average of 8.27 cases per 100,000 people per day. And we can use that number to help us understand how widely the disease is spreading in our community. And this is a tool that our school districts can use as well, just to think about how prevalent the disease is in our community. And so the Fairbanks North Starborough School District just released what is called a risk level decision matrix. And this is a matrix to help risk stratify the community into a low risk time, a medium low or medium high risk time, and then a high risk time. And so a low risk time is when we're seeing less than 5 cases per 100,000 people per day, averaged over a 14-day period. And in general, what that represents is a low or a controlled transmission of the virus in our community. It doesn't mean that there are no cases or that there will be no cases, but it means that at that time, the overall transmission is well controlled. In this medium risk zone, we're looking at the 5 to 10 cases per 100,000 people per day. And that's the yellow zone. That's where we're seeing that there is significant transmission of the virus in our community. And lastly, we have the high risk zone, where we see greater than 10 cases per 100,000 people per day. And that's when we know that there is widespread transmission in our community. And we need to think about taking significant steps to limit the spread of the infection. When we look at where we're at right now, we're at 8.27 cases per 100,000 per day. And that's putting us right about here, at the upper end of the medium-high zone. Now, this is just one tool that we have to understand the spread of the virus in the community. And it's just one tool that we can use to estimate how quickly the virus is transmitting. There are many other tools, and this has to be put in context with a lot of other information that is coming into our public health department and to our healthcare professionals. So lastly, and maybe most importantly, I just want to talk a little bit about the tools that we have to control the virus. What is our tool set when it comes to COVID-19? And I'm going to break this into 2 different sections. First, I want to talk about the public health tools. What tools do we have at a local, city, state, and federal level to help control this virus? And then I want to talk a little bit about the individual steps that each of us can take to protect ourselves, to protect our family, to protect our neighbors. So first, in terms of the public health steps, the first and most important thing is testing. And having high quality testing in a community is generally composed of 3 different parts. First, tests have to be fast. They have to come back and we have to get an answer in a reasonable amount of time that lets people know if they have the virus or not, and then lets them act on that information. If testing takes too long, if it takes 1 week, 2 weeks, then individuals might get their results, but it might be too late to act on them. The second part of testing is we have to know that the tests are accurate. We have to know that in general, when we get a positive test result back, that means that an individual does have the virus, and when we get a negative test result back, that means that an individual doesn't have the virus. Now, no test is perfect, but we want to get the testing as accurate as possible. And third, tests have to be available. We need to know that we have enough tests available that we can test anyone who thinks that they may have contracted the virus or who thinks that they may have symptoms. And we need to have enough tests available that the results can inform our public health department and inform our schools and inform our healthcare professionals about the prevalence of the virus in our communities so that we can all take the appropriate steps to mitigate it. And so what are those steps? The next thing I'm going to talk about is contact tracing. And this is a term that has come up a lot recently. So what is contact tracing? Contact tracing is something that happens through the public health department, where when I go and I get tested and then I get a positive test result back that means that I'm carrying the virus. I will then get a call from someone at the public health department, and they'll be asking me a few different questions. What are my symptoms? How long have I been having these symptoms? And then most importantly, who have I been in contact with who could potentially be at risk of catching that virus from me? And that tracing of all of the different people that I have potentially been in contact with is so important, because that lets us as a community give those individuals a heads up and say, hey, there's a potential that you may have been exposed. Are you having any symptoms? Do you want to be tested? And that's what lets us take additional measures to help to mitigate the spread of the virus. The third thing that I want to talk about are policy actions. And these are actions that are taken at the governmental level to limit the spread of the virus. We've seen a number of different policy actions taken in different communities throughout the United States. So I'm just going to name a couple of these. First are policies around masking. This includes mandating masks in public spaces, in grocery stores, etc. The second policy step are limits on crowds. And we've seen different limits in different cities and different communities of limiting crowds to under 100 or under 50 or even under 10 individuals. And then third, and the most significant step that a government can take, is a stay-at-home order, also known as a shelter-in-place order. And this is a response to widespread community transmission in a town or in a city. And this is a government asking people to please stay at home, please don't leave unless it's absolutely necessary, so we can take significant steps to control this virus. And so that's what can happen at a government level. But perhaps more important than that are the steps that we can take as individuals to help control the virus in our community, but also to protect ourselves, protect our friends, protect our family, protect our neighbors. And so the first thing that we can do is practice physical distancing. As we talked about earlier, we think that these droplets can go on average about 6 feet. And so that's where that guidance comes in. To, wherever possible, remain 6 feet away from others to help prevent our droplets from reaching others and to help prevent the droplets of others from reaching us. Second, we need to think about masks. And there have been a lot of questions about what mask to get and which. Find a mask that's comfortable for you and please wear it. We know that masks can prevent us from inhaling droplets and aerosols that are around us, that are emitted from others. But they also protect others from any droplets that we have, that we are sending out into the air. And so I don't feel any of the symptoms of the virus, but I can't say that I don't have the virus. I can't say that I don't have the virus and I'm just asymptomatic. And so as a sign of respect to others, I'm going to wear a mask to prevent the droplets that I'm emitting when I'm speaking, when I'm breathing, when I'm coughing, when I'm sneezing, from reaching others. The third thing that we can practice is hand hygiene. This means washing our hands with soap and warm water whenever able. This means using hand sanitizer so that if we come into contact with droplets on any surface around us, that we wash them off before we're touching our mouth, our nose, our eyes. It also means washing our hands before we take off our mask or before we put back on our mask, so that we don't transmit droplets or virus from a surface onto our mask, because that's a great way for those droplets to get near us and to infect us. And then fourth, we need to think about getting tested when we feel symptoms. So if we have any of the symptoms that we talked through earlier, it's important to let our doctors know and to reach out and to say, hey, it would benefit me to know if I have the virus or not, it would benefit my family, and it would benefit the community. And so it's really important if I have symptoms that I reach out and that I get tested. And so those are the four things that we can think about as individuals to take responsibility for this virus and to limit transmission and spread through our community. So we've talked about a number of different things here. We've talked about the science of the virus. what its symptoms are, the different ways that it can spread. We've talked a little bit about epidemiology and how the virus moves through the community and how the number of cases we see and the transmission can change based on the steps we take to mitigate the virus. We've looked at Fairbanks specifically and how we're seeing the virus move through our community. And then lastly, we've talked about these different steps that we can take as a community and as individuals to control the spread of the virus. So at this point, I'm going to hand it back to Dr. Nace to review some additional topics. Thank you so much for listening to me.
So one of the questions we get is when we use this word PPE, what's PPE and what does that mean? And it stands for personal protective equipment. And I have a couple of examples I'd like to show you and be able to put on and show you what it looks like. So when we're dealing with people who may potentially have COVID-19, there's certain equipment that we would put on to help keep us safe as well as others. So if I had a patient that needed to be tested, had symptoms that were concerning COVID-19 or and wanted to be protected, the equipment that I would use is first I would put on a gown. And these gowns are simple gowns that put on this way. They tie up at the top and they tie in the middle. I would then also put on a mask. Now, there are multiple different types of masks out there and available. And so I'm going to go, before I put the mask on, and just talk a little bit about masks. You'll hear a lot about cloth masks, which is what's recommended when you're out in public. A cloth mask is one, you can see a lot of homemade ones. There's different shapes, there's tie-ons, there's ears, and it will look like that. When I am just taking care of patients, and in the medical setting, I might be wearing what's called medical or surgical mask, and that's these medical masks. And that was what was in short supply, which was one of the reasons why there was so much push to wear a cloth mask, homemade mask, to save the medical mask for those in the medical profession. And that's what this would look like. Now, these will help with, as we talked about earlier, taking away your risk for droplet that might come in, but they're not as good for aerosolized. So then we have what you might have heard is called an N95, and this is an example of an N95 mask. And the difference being is it's fitted. I get fitted to see what size N95 would best go on. So when I put on the mask, it actually can be molded to my face. It's not only taking out droplet precautions, it's helping any aerosolized that would enter into my nose or mouth. So this is what this looks like. This is an N95. I push it down on my nose. It forms around my face and makes a seal to help from aerosolized also getting into it. Now, there are additional ways in which you can also protect, and what you might have heard is like a face shield. So there are different types of face shields, and this would be one that you could wear that would give additional coverage. So there have industrial strength face shield, but we also have face shields that look more like this and are a little lighter. This would go on top here. And again, now I have a face shield which is covering this way as well as covering that way. Now, I don't need to wear both of those if what I am wearing is goggles. So I have glasses on, but the glasses also have space on the side. So even if I'm wearing my regular glasses, I still need more protective goggles. And an example here would be these simple disposable ones that we might use in the medical setting, or also reusable goggles, which would be more shaped like goggles that would go over my glasses, which would look like this. So now my eyes are more protected over my glasses. The N95 is helping for aerosolized. And if I knew that I needed to do a test on someone who was concerned had COVID, I would then put my gloves on. And then I am in full PPE. So as long as I am in full PPE, I'm going to go on to the next demonstration, which is how do we do a nasal swab and how do we test for someone? And because I'm protected, I am going to ask my patient, Dr. Bridgman-Packer, who we now know needs a COVID-19 test. So this too, the testing that we've done has changed over time. There are different parts of testing where they can go all back further, which some people felt like they were tickling their brain. But currently, different labs, depending on, can do different sources. What we're going to show right now is how to do an anterior nasal, meaning the front part of your nose testing. We are also able to do what's called self-administered. So I don't need to do the test, but I am going to supervise as have the patient do it. So I'm going to hand the test kit, the swab, over to the patient and have him perform his test.
Great. Now some of these come with 2, but we only need 1, so I'm just going to take one of them off here. Whoa.
There you go.
I'm going to hand that back to Dr. Nace. So I have the swab here. I'm going to make sure that Dr. Nace is 6 feet away from me. I'm going to take down my mask. I'm going to place the swab in the front part of my nose and then make circles with it for 10 seconds and then do the same with the other nose.
And I'm going to help by counting. 1, 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5, 1,000, 6, 1,000, 7, 1,000, 8, 1,000, 9, 1,000, 10, 1,000.
I'm then going to do the other nose.
1, 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5, 1,000, 6, 1,000, 7, 1,000, 8, 1,000, 9, 1,000, 10.
And then I'm going to replace my mask. The swab that I've used then goes in a test tube. And that then goes to the lab.
So that is how you do the part, but then what happens with the actual sample after that? So once I have the sample, then where this goes depends on who is actually doing the test. So I am going to, as we get over here, I'm going to take off my PPE, and that is to allow me to be heard better. But normally had this been, I would continue on my PPE until after I got my swab done. So I'm going to first take off my gown. Oops, I'm not going to do it that way. And gloves. And I would put them in the trash after using them. But since these are our sample ones, I'm just going to put them right here. I'm going to take off my goggles. And then I'm going to remove my mask. And then I'm going to sanitize my hands. So that is how you would see that done. That's done for both testing as well as seeing patients who you might be concerned have COVID. So then once I have the sample and I send it off to the lab, there's different places that it can go. And so some of the questions is, why does testing take so long sometimes? Why does it take me 5 days, 7 days or longer to get my test back? When we have the sample in the media, then we're going to send it to the lab. So that sample might be sent to different locations. One possibility is it might go to an outside commercial lab. So it might go to this commercial lab. And those, some of the names you might hear, like the Mayo Lab or LabCorp or Quest Lab. And then that is sent out of Fairbanks to another location where it's tested. Now, depending on the equipment they have, the reagents they have, the number of people they have in that lab, that could come back as soon as 3 days, but it could take longer too, depending on demand. Sometimes it can be up to 10 days that it might come back. That sample might go to what we call is the state lab. And that's right here in Fairbanks, or in the case of Anchorage's, it might go right to Anchorage. And that is then processed right at the state lab. So that test, ideally, because we don't have to send it by airplane because it's right in Fairbanks, ideally that could come back in 24 hours. However, if they also are backed up on number of tests, the number of people they have, the number of reagents or other difficulties, it could take longer. So the goal might be 24 to 48 hours, but in cases of where we have a huge number of tests and not enough time, that can take anywhere from more like 5 to 7 days. That's not the goal, but that's just the result of what can happen when the system is overwhelmed. The other place that that sample can go is right there to your local clinic or the hospital. And what those we're going to call those more our rapid testing. And that can be done in a quicker fashion, but the downside is they can only be done less at a time. So if you're going to do some of the rapid tests that might come back in like 15 minutes, you can only do one test at a time. So if you have a bunch of tests that you need to be done, you can't run a huge number. You can get the results back quicker, but you can't run a huge number at a time. So those might take you just a matter of minutes, anywhere from like say 15 minutes that it comes back. But again, one sequentially after another. You can also have it done, if you hear like some of the outlying communities have those tests available, they can get it done quickly like that. But if they have a huge number of tests, then they can't support that number. So what are the different things that slows down a test? Well, there's lots of different steps which, if we have limitations, can result in tests coming back longer than the ideal goal. So the first one, it could be that we don't have those actual swabs that they have, that we're low on swabs, and that happened during the course of this pandemic. It could be after we had the swab, we put it in the media for it to be transferred. It could be that we're low on that media. Once it goes to the lab, it could be that the lab doesn't have the machine necessarily to run it. Or it could be that we have the machine, but we don't have the reagents that the machine needs to make it process. Or it could be that we don't have enough people currently employed at that particular lab to keep up with the numbers. It also could be that the number is simply overwhelming to that particular system. So all of those things come into play that lead testing that normally we might have a goal of doing it in 24 hours, but in reality, in certain periods of time, and we're on that part of the curve that's higher, we can't keep up for those different reasons. Also, as we're aware, there are different parts of the United States that are having more difficulty with the numbers. And so federally allocated supplies that might have been earmarked to go in one location are being reassigned to go in areas where their numbers are so high that they need more of the supply that they might be missing. And secondarily, what happens is other communities might have a lower number than is ideal for them. So that concludes with the part of PPE and talking about testing. I wanted to talk about another area where there's been some confusion about what is screening versus testing. So a lot of times people might use those words interchangeable, but they're different. So when you talk about screening for COVID, that involves questions that you might be asked, like, have you traveled anywhere outside of Alaska? Are you having any symptoms? Have you been around somebody who's been positive? It might even be a temperature that's taken to see if your symptoms. Those are screening questions. And those questions you might get on the telephone before you go to a clinic visit or to the hospital or to a dentist or other businesses, or they might be ones before you walk into a building. You might see a sign out that front that says you're going to be screened before you can come in. And that might be one you see at a clinic or potentially a school or other buildings, that they're going to ask you those questions and go through a symptom checklist to make sure that they are keeping the employees in that building and other patrons of that building as safe as possible. Now that is different than testing. Testing is the actual act which we just demonstrated, where a sample from your nares is being sent to a lab to see if there's actually evidence of virus in there. That concludes the procedure part of our talk, and so we'll go on next to talking about schools.